Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast, and today we have another guest. His name is Dr. Munir Ghesani. He is a medical physician. He's the chief medical officer at United Theranostics with 30 plus years in nuclear medicine, specializing in theranostics, oncologic imaging, and targeted radiopharmaceutical therapies. Dr. Ghesani, welcome to the Thyroid Answers podcast. How are you today?
Good. Thank you, Eric. I appreciate the invitation.
So the podcast, primarily we're talking to people with some level of a thyroid condition. So we'll try and keep the beginning part of this discussion relevant to them. But I said a couple terms there right off the bat that people may have no idea what these things are. So we might as well cover those right off the bat.
Sure.
What is nuclear medicine and why would it be relevant to anybody with a thyroid related condition?
So actually, that's such an interesting question because I can give you a historical perspective that dates back to 1940. And in fact, the whole field of nuclear medicine originated because of thyroid. Mm-hmm. And so back in 1947, Dr. Compton was the president of MIT. And one of the nuclear medicine physicians was attending a conference, and the topic of the conference was, what can engineering do for medicine? Interesting topic, right? Back in 47, the title, he delivers a lecture. After the lecture was over, Dr. Sol Hertz, who's a nuclear medicine physician, meets with Dr. Compton and says, I have a question for you. He says, can I make iodine radioactive? And that was very intriguing to Dr. Compton. The discussion started, and ultimately that resulted in the very first iodine treatment, radioiodine treatment for hyperthyroid state, for hypothyroidism. So then several steps occurred afterwards, which ultimately resulted into the new field in medicine called nuclear medicine. So if you have to look at the closest approximation of nuclear medicine over the several decades was with imaging side. So a lot of nuclear medicine from that treatment actually morphed into imaging because there were new types of scanners that were introduced. And the idea was that most of imaging in medicine occurs based on anatomy. But oftentimes, anatomy in the body does not change much, but the physiology changes it in a way that could give the symptoms. Right. So some patients feel the symptoms, you do the scans, CT scans or MRI, you don't find anything. But if you apply nuclear medicine techniques, they in fact find diseases when there's no anatomical disruption. So another way to put this in would be nuclear medicine is a physiology-based modality. And what's interesting is that the prototype started off with therapy. A lot of effort subsequent decades went into imaging side, but now we are coming together with another new technological breakthrough that occurred with the genetic mapping and human genome profile that now allows us to use that same principle back into treatment. So we are going full circle where we started prototype of nuclear medicine with therapy, subsequent decades on imaging, and now tying imaging and therapy into two very core components into one modality called Theranostics.
Okay.
This is where our title of United Theranostics comes in, where we are now combining diagnostic and therapies intertwined into each other.
So are you combining that term together because the same practitioner is doing the imaging and the treatment versus in the past, you went to somebody who did the imaging and the person who did the treatment was a separate person. And so there was something lost in the translation from imaging to therapy?
Absolutely. And so that's one of the reasons, but not the only reason. The other more important reason is that when we are treating somebody, let's say you're giving somebody a chemotherapy for a given cancer, that chemotherapy, once it goes into the body, or immunotherapy, you don't have a control over it. Once it goes, it just finds the cancer cells because they are rapidly dividing, but their normal cells are also dividing. And so chemotherapy would address the dividing cells, which means that the reason why a lot of patients with chemotherapy experience symptoms, hair loss and fatigue and bone marrow suppression, all of that, is because chemotherapy is not selective. Whereas when we do the theranostics, it is selective in a way that we, in fact, first use that molecule target for imaging. We confirm that that target is taking up our image, and then we modify the radioisotope that goes and treats, so that it's just not only one person does both, but it allows us to see what we're going to treat. And then once we treat, our different type of scanners allows us to actually see our own treatment as well. So they are tying in so well that it works very well. And the perfect example of this is iodine 131. And in fact, if you look at the birth of Theranostics, was that same example that I gave you of Dr. Compton and Dr. Hertz, which is where the Theranostics started, because interestingly, iodine 131 does both in a single molecule. It has gamma rays that allows us to see the body from outside, exactly where the iodine is going, but it also has beta rays that actually treat wherever the iodine is. So in a way, iodine 131 was a very first prototype theranostic molecule that we still use today.
So we've covered what nuclear medicine is. We've talked about what theranostics is. And then from a radiopharmaceutical, help somebody understand what that means in kind of more layman's terms.
So the best way to put that in the layman's term would be that the iodine 131 is the purest form of radionuclide. So, it just basically is produced in a reactor. It's a byproduct. And then it's used sodium iodide is how it comes out. You give it to the body. But not every other types of cancer in the body is so readily targeted with simple radioisotope like iodine.
Mm-hmm.
So radiopharmaceutical means that you have an isotope similar to iodine, let's say, for example, lutetium-177 or actinium-225, and then you have to then attach it to the molecule that finds the cancer cells in the body. So this is kind of a bridge. The pharmaceutical is a bridge between the isotope that treats and the target in the body that needs to be attached to. So that's what's called radiopharmaceutical.
You're using a drug attached to this radioactive particle.
Correct.
The drug's the carrier vehicle, essentially the Uber, to get the radioactive treatment into the cells.
Right.
Is that fair?
So that's actually a very perfect analogy, because imagine the treatment is sitting inside the Uber.
Mm-hmm.
But the person who's sitting inside doesn't know where to go for the target. So Uber takes that person who is treating to that target, and once the target is attached, that person inside the Uber is actually the one who is treating that cancer.
It's out, does its job, and it's done, right?
Yes.
Okay. So we've got these big topics. So from people with thyroid physiology, the people that we're thinking that are concerned that we might use a radioactive treatment, who were the population, before we get into the new therapies that you're doing, who would be the population of people that would primarily be going to see somebody in nuclear medicine if they've got a thyroid condition? Primarily people with thyroid cancer, Graves' disease?
Yeah, so there are, there are two different broad applications for patients with thyroid disease to come to nuclear medicine. One would be a hyperthyroid state.
Mm-hmm.
And what happens is that there are two different ways the patients, and there are actually many ways, but two ways that patients will come to nuclear medicine with hyperthyroid state for treatment with radioactive iodine. One would be the Graves' disease, and the other one would be what we call hyperfunctioning or autonomous thyroid nodule.
Mm-hmm.
So either the whole gland is overproducing the hormone,
Yep.
or there's a specific nodule inside the gland that is so predominantly producing the hormone that the patients become hyperthyroid. And in those both situations, there is a very clear indication for radioactive iodine treatment. The reason being that you're just giving one pill, it is taken by mouth, and that pill finds its target once it goes through the body's circulation, and you don't have to do any surgery. You don't have to take a lifetime of medications such as methimazole or tapazole, which can cause side effects on the long term. So this is very easy and very readily accepted modality for hyperthyroid treatment. So that would be one segment. The other one would be thyroid cancer.
Mm-hmm.
And in the thyroid cancer setting, we treat in very different stages. So it could be in the initial diagnosis when the patients undergo surgery, the thyroid is removed, and we come in and give the radioactive iodine, which is called adjuvant therapy.
Mm-hmm.
So in that case, the idea is that if there might be, even though surgeon may have removed the entire gland, there may be some micro metastatic, small, tiny lesions that have spread outside that the surgeon could not see. But once we administer the iodine, it decreases the tumor burden and hopefully it wipes it out. So the patients have a very long-term favorable outcome because we have not really removed the bulk of tumor by the surgeon, but we have also gone in and administered radioactive iodine treatment.
That was I'm sorry, go ahead.
No, go ahead.
So that would have been the standard care previously.
Correct.
Radioactive iodine, surgical removal. You got a person who's going to be chronically hypothyroid. We put them on medication moving forward, but we've dealt with what's happened at the gland and disease. Was there problems and complications with that model that has led to where you're at today with what you're doing? Like, is everybody moving into this therodiagnostics or theranostics, or is this something more specialized to your group?
No, so the theranostics practice in general is very heavily regulated. Because we are dealing with the radioactive materials, and these are, prone to, they require very strict handling techniques and expertise.
Mm-hmm.
So there are every aspect you have to think and take into consideration. First of all, your patient, to make sure that you don't overtreat or undertreat. Secondly, the staff members who are administering these treatments, and then general public. So all of these require that there are several regulatory agencies that are involved in this, not only the health agencies, but even Nuclear Regulatory Commission as well. So which is where the expertise comes in. So you need to be very familiar with administering these. And that same concept that started with thyroid cancer treatment also applies for newer applications, including currently there are two other major areas where these treatments are approved. One is in the neuroendocrine tumor and the other one is in the prostate cancer. But that concept that started with the iodine treatment for thyroid cancer is continuing on to application of theranostics in all other cancers as well. So going back to that question that you asked, the thyroid cancer, typically the first step in the management is surgery, because if there's a lot of thyroid gland existing when we give our treatment, it doesn't go to specifically thyroid cancer, it may go to normal thyroid as well. So these patients need to have their thyroid removed, and only then we can go in and treat with radioactive iodine. But then there are situations when the patients may come back down the road 4, 5, 6 years later when the cancer comes back. And if it's still expressing the attention for iodine, we can go and treat those patients in a more therapeutic way as well. So our treatments are given in various stages of the cancer. And that is not just unique to thyroid cancer. it's also unique to other cancers as well, because depending on what stage of the disease these patients are, increasingly now there's a focus, for example, in prostate cancer, that if we go sooner when the cancer is spreading, we have better outcome of the patients.
So is this we'll stay with the cancer treatment. Has the standard of care been up until this Theranostics approach has become more kind of established? Was the standard always somebody's got thyroid cancer, we're just taking the whole thyroid gland out, or was it that we take out a part of the thyroid gland? What had been the standard? And then with the new Theranostics approach, has that standard changed? Is it still take out the whole gland, or are we taking out part of the gland? Or with the new approach, can we leave the gland and just target the abnormal cells?
No, so currently there's still no solution for leaving the gland and targeting the theranostic cells. So I can give you the idea of how the treatment paradigm for thyroid surgery are changing.
Mm-hmm.
So back in 80s and 90s, the most patients would get only part of the thyroid removed. And the reason for that was that at that time, if you remove the whole gland, then you need to supplement with the thyroid hormone.
Mm-hmm.
And at that time, thyroid hormone were made out of cow's thyroid. We used to call it bovine
Mm-hmm.
thyroxine. And while it served its purpose, it was also immunogenic. So some patients would get reaction because this is an animal product and it's being given to human. So at that time, most patients underwent only partial thyroid removal. And then over the 90s, the new technique came out called human recombinant thyroxine. So that human recombinant meant that it is no longer having animal product.
Mm-hmm.
It's so much well tolerated. In fact, the newer thyroxine is one of the most commonly prescribed drug in the world because it's so well tolerated that you don't have to worry about only removing part of the gland. So then the paradigm shifted to removing the entire gland. Now, currently, there's another shift in paradigm where many surgeons prefer to only remove part of the gland. And the idea behind that is that you have to be very careful in selecting which patients go through that process. So if the thyroid cancer is found in a very early stage, it has not broken through the capsule, there are no lymph nodes in the neck, and if everything looks favorable, it's very small in size. In that case, they think that if they just remove part of the gland, it is essentially quote unquote curative. So in that case, you don't need to do anything else. So going back to your question about can you then give the Theranostics approaches, the answer is no, because the rest of the thyroid is still there. If we give a very high dose iodine, that thyroid will become inflamed and cause a lot of symptoms. And also our treatment will not go to the cancer cells, but go to the normal thyroid. So I think in the foreseeable future, there will never be an indication to give the radioactive iodine to those patients who have only part of the gland removed. We can only go in when the entire gland is removed. So it clears the field for us to then target our iodine to preferentially and selectively only to the cancer cells.
So, yeah, so that's a challenge. So there's at this point, with this type of treatment, it's, and I may say this wrong, so you can correct me if I say it wrong, but the treatment to a thyroid gland would be, it's more like napalm. It's going to hit the whole thing, and therefore it's better to have it removed, and then the treatment's going to remove or damage any remaining
Correct.
cells. Now, somebody might have a question, well, if you're providing the iodine, what prevents the iodine from damaging other cells or other tissues in that area? And so I'm sure it's probably good to just explain why iodine is so helpful from a thyroid perspective in being able to treat, and maybe why it wouldn't potentially damage surrounding tissue that's non-thyroidal.
Yeah, that's a very great question. It's so relevant to this discussion because, whenever we sit down with our patients and when we explain the treatment process, we inevitably bring this into discussion. So it's very relevant to what occurs in our practice with every thyroid cancer patient. So fundamentally, only tissue in the body that has anything meaningful use of iodine is the thyroid gland because it uses that iodine to make the thyroid hormone. While we would like that to be the case where no other organ in the body takes the iodine because they don't need it, we still have to administer it by the pill. So that pill goes into the stomach, gets into the circulation, and then ultimately it ends up in the thyroid gland. But in the process, it's also going through the other parts of the body. So, for example, salivary glands are taking it and then excreting that out. So why is this important in our context is because we have to give the instructions to the patients to protect other organs that are processing it, and then ultimately it clears out through the mouth into the gut, into the stool, and a predominant part comes out into the urine. So when we talk to our patients, we want to make sure that they protect their normal organs, but they also protect their family members and colleagues and general public. So the instructions include proper handling of the stool and urine and salivary glands. So we tell them not, first of all, hydrate significantly so that it clears out faster. There are some data that if you wait for a day after administering the iodine and then give them stimulation for salivary glands, such as sour candies or lemon wedges, that excretion takes place in a much faster way, so it protects the salivary glands. The lacrimal glands, the eyes have the ducts that are also carrying the iodine as well. So we protect the lacrimal glands, the salivary glands. We protect the other organs by increasing the hydration, tell them to go to the bathroom as often as you can so that the urinary bladder doesn't become the retention of the iodine and it irradiates the bladder. So all of those instructions are important because of precisely the reason you said, is that other parts of the body that handle the iodine. They handle it just as part of the processing, but once the iodine is deposited into the cancer cells, that stays on for a very long time because iodine has a half-life of 8 days. And so effectively for about 8 to 10 half-lives, these cancer cells continue to receive the iodine, which is why these treatments are so effective, because they are stored into the cancer cells and they are cleared out of the rest of the body.
So for the listeners, it's important, we've probably talked about this many times, but the thyroid cells take up iodine to make your thyroid hormones. And what we're using here is a radioactive iodine to be taken up by the thyroid cells and hopefully by these cancerous cells. And as they take up that, essentially this Uber, and it has this radioactive iodine, it'll actually damage the cell. The reason they're saying, hey, take out the thyroid, just take out the whole thyroid gland is because they can't be indiscriminate with what cells are going to take up the iodine. All the cells can. So this is a strategy. I do wonder, immune cells, especially neutrophils and other of these phagocytic cells, often use iodine, and one of the things that's in the literature is how they can pull iodine from thyroid hormone to utilize it to make a potent antimicrobial. So with radioactive treatment, is there any change that they see in immune cell function, drop off in, let's say, neutrophil function, monocytes, macrophytes, with radioactive treatment?
That's a great question too. And the answer is generally no. And the reason for that is that the iodine that we take in our diet is, typically in many milligram quantities. The beauty of our treatments, and this is not just unique to thyroid cancer and iodine, it is for every other treatment where the theranostic approach is applied, is that the actual weight that we use for delivering these treatments is in the nanogram to microgram. It is so small that it does not cause any major pharmacologic effect to the body. The reason why it is so powerful is that despite that nanogram or microgram quantity, it knows exactly where it needs to go. And as a result of it, we can get away with minimal dose. And the tolerance, whether we apply these treatments for thyroid cancer or neuroendocrine tumor with what we call the lutetium dotatate, or with prostate cancer with lutetium PSMA, is that these are molecular weight is so small that it's way under the radar of the body to even find out that there was anything from outside given to the body.
Okay. And then from a post-treatment perspective, we know that perspiration, you can lose a bit of iodine if you're sweating and exercising as just a regular person. How is there a benefit to somebody who's going through the treatment to go and exercise, sweat, be in a sauna, or would that be highly advised against?
Well, we usually advise against because it doesn't alter the ultimate effectiveness of our treatment, but what it can result in is that sweat can be carrying the iodine, so it may become a potential contamination. So we typically advise our patients for at least the first. It's interesting how that iodine circulates in the body. It has two different components, and this is very well studied in what's called compartment modeling. So the first component is where it's washing out of the rest of the normal tissues, and that component is about 3 to 4 days. So after about 4 days, very minimal iodine is freely circulating. It's just being handled mostly by the thyroid cancer cells and then by the salivary glands that are excreting out into the stool and into the urine ultimately through the blood circulation. So if they follow these instructions for the first 4 to 5 days of avoiding that heavy exercise, after that, if they have perspiration, that carries very little iodine afterwards.
So there's different types of thyroid cancers. And is the treatment that you're doing currently, is it able to treat all of the cancers, or are these cancers, the cancers that you're going after have to be ones that are very responsive to iodine? Is there
another great relevant question? So there are there are many subtypes of thyroid cancer, but I would describe them in 4 major components. So that includes papillary and follicular are 2 types. Combined together, they are called well-differentiated thyroid cancer.
Mm-hmm.
The third one is called medullary thyroid cancer. And then the fourth one is called poorly differentiated, undifferentiated, anaplastic. There are multiple names for that. Mm-hmm. So the last 2, the medullary and anaplastic, don't take much iodine. So we usually don't treat them with radioactive iodine. We only treat papillary and follicular. And interestingly, these cancer cells also evolve. So if there is somebody who had papillary or follicular cancer, it doesn't always stay that way. It may still have some profile, but it may start to differentiate into other types, including poor differentiation. Interestingly, now there are many treatments that are available. So if somebody has a cancer that was initially expressing iodine avidity, and then it starts to lose the iodine expression, you can actually give the treatment that can, what we call redifferentiation, so it can bring their avidity for iodine back. So these are done in a stepwise manner where we first, again, that's where the concept of Theranostics comes beautifully. Because first we do a scan and we look at the expression and we say, oh, well, we know this is where the cancer is, but that cancer is not expressing iodine. Let's put that patient into the redifferentiation therapy. Patient goes into redifferentiation. We repeat the scan and confirm that now the iodine is being expressed there, and then we go and treat. So it's a very sophisticated approach where you in fact prepare the patient's cancer cells to make sure that they take the iodine where they initially are refusing to take it.
So what is what are we looking at on the imaging to determine, hey, this is a cancer cell, this is not a cancer cell? I know there was a story, and this isn't necessarily my forte, but back in the day, I think we looked at hurdle cells as one of those cells that we said, these are cancer cells. And then there was a discussion and I think it was Hurdle himself who said, not all of these are cancer cells, right? Maybe we shouldn't be doing as many thyroidectomies as we're doing, and maybe we should, kind of change our thought process. What are we looking for? What's the process? Are we seeing a biopsy and seeing abnormal cells, and then we're using the imaging to try and figure out where exactly, how widespread this is? Can you walk us through that a little bit?
Yeah, that's such a relevant question as well. We in fact, not a week goes by where this discussion does not take place. As you know, our clinical management now is in the multidisciplinary tumor board, so it's not just one specialist saying this is a treatment. There are multiple specialists who come together, review a given patient's profile, and decide this is the treatment to give. So in this instance, I can give you an example. Somebody, the way we monitor the thyroid cancer is using the thyroglobulin, right? Mm-hmm. So that's a marker. Somebody's thyroglobulin comes out and increases after 4 or 5 years or so. Then we know that there's cancer. That's where the imaging comes into place. The beauty of current imaging techniques is that we can now combine what's called hybrid scans. So there's a functional scan, which is a SPECT scan, or a PET scan, and then there's a CT scan, which is anatomy. Mm-hmm. So we hone into the anatomy, we find that there's a little mass that came in, and that mass is seen on the CT scan. Now, is it taking iodine or not? If it is not taking iodine, and then you do the biopsy and you confirm that it is actually thyroid cancer, but it's not taking iodine, in that case, we go back and go into that redifferentiation therapy and repeat that whole process again after 2 months. And now that mass is still there on the CT scan, but unlike first scan where we did not see the iodine, on the second scan, we confirm that iodine is now being deposited there. Then we know that this is an ideal candidate for iodine therapy, which would not have been the case 2 months ago. But after the redifferentiation, now that patient is a candidate for treatment.
So before this redifferentiation process, what would have been the treatment for that person with an iodine or a cancer cell that doesn't have the avidity for iodine?
So in that case, they would have either surgical option to remove that cancer, or they can do what's called external beam radiation therapy. So that instead of giving the iodine from inside by giving a pill, they deliver the radiation from outside.
Okay. At what point, and maybe this is just outside the wheelhouse of what you do, but I guess maybe the first question should be, thyroid cancer probably more prevalent today than maybe it's been in decades. Why?
So there are multiple reasons. There are some environmental factors that are attributed, but I think in a large part also because there's imaging being done so much more frequently, that it results in detection of these cancers that otherwise would have gone undetected. Now, there's always this discussion of whether each and every cancer that was detected would it have made a difference in the outcome of patients. And the reason is that there are many autopsy studies that have shown that patients may be harboring the cancer all their lives, mm-hmm. but it didn't really result in any kind of untoward effect to the body. So we have to be very selective in identifying and treating only those cancers that are more aggressive and that are the ones who are going to affect somebody's outcome.
And this is, I guess, to some degree and we'll shift to that discussion here in a little bit when we talk about prostate, right? Because almost every man as they get older, it's thought that may develop some level of abnormal cells in their prostate, but at what point do we intervene, and how much do we intervene in people from a prostate cancer perspective? All right, so I guess the next question I would have is, with the shift from what the standard of care was to this new Theranostics model, are we seeing, or is it too early to say that this treatment strategy is more effective at preventing reoccurrence of thyroid cancer?
So the theranostic approach for thyroid cancer has been applied all throughout since 1940s when it came out. And yes, to your point, one of the pioneers in really proving this concept was Dr. Ernest Mazzaferri. And he was very thoughtful, thinking decades ahead of his time. His idea was that, well, if we want to see the difference it makes in the outcome, there are two major challenges with thyroid cancer. Number one, at least at that time, it was not as common as it is today. So in order to do a trial, you need a large number of patients. Secondly, unlike other cancers that are deadly, like lung cancer, where patients are not, they're diagnosed at a stage 4 disease, they're not living much past few years. Whereas thyroid cancer patients live a long time. So if you intervene, are you intervening and finding the difference just because your treatment worked, or that's a natural course of thyroid cancer? So it required thousands of patients, number one, and studying them for a long time to make sure that it makes a difference or not. So what he did was he designed a trial where they studied several thousand patients, but they studied them for almost 2 decades. Then divided those patients into an arm, they call it the control arm, where they did not receive the radioactive iodine. And then the active arm is where they gave them the iodine. And then they followed them. And they found that those patients who received iodine lived much longer than those who did not. I mean, obviously, there's more intricacy into the plan where you need to select the appropriate patients. Not every patient needs iodine treatment with thyroid cancer. So they selected those patients, and those criteria continue to be refined over time. But it's still, we are finding that the literature continues to support that when you add the iodine, radioactive iodine treatment in the appropriate setting, that it does help in extending the life and also reducing the recurrences as well.
And you may not know this answer, do you have any idea what percentage of people that are coming in diagnosed with thyroid cancer are already diagnosed with hypothyroidism and on thyroid medication?
It's interesting. Majority of the patients who come diagnosed with the thyroid cancers don't have the symptoms of either hyper or hypothyroidism. Yeah, there are certain conditions in the thyroid that predispose somebody to develop a cancer, in which case they may be hypothyroid. And because of the thyroiditis over a long time, those patients may be under the care of an endocrinologist, and they were continuously monitoring them. They find a nodule, they suspect that it may be thyroid cancer. There are also data that show that when the patients are hyperthyroid with Graves' disease, if they are found to have a nodule in addition to the Graves' disease, that likelihood of cancer is higher. So yeah, there are situations when patients who are either hypothyroid or hyperthyroid may get diagnosed with thyroid cancer. But I would argue that majority of the patients who are found to have thyroid cancers are actually not receiving the care or not coming to a detection because of either hypo or hyperthyroid symptoms. They are under detection pathway because either the nodule has grown so much more that they're noticing it by themselves, or their regular physicians who are going for a preventive care may find it, and then they ultimately diagnose it by biopsy. And increasingly, they are being now diagnosed because of imaging techniques are so much more commonly used. So whether that's ultrasound or CT or MRI or PET CT scans that are done for some other reasons, but they incidentally find a thyroid nodule, and that gets biopsied and ultimately turns out to be the thyroid cancer.
Yeah. And this is probably not the discussion for you, and we'll probably switch gears, but there is some literature talking about how, especially in patients that have thyroid cancer, then have their thyroidectomy and have their treatment and then go on thyroid medication, have a greater incidence of other cancers. Are you aware of some of that literature?
Yeah, so I'm aware of that literature, and in fact, there are also, interestingly, there are other correlates of thyroid cancer that have been discovered. So, for example, if you have somebody who had received a radiation for lymphoma or breast cancer, and if the thyroid was in that field of radiation, there are data that they develop the thyroid cancer. So there are certain correlates of that, but there are also other correlates. For example, if the patients have mutations, and those mutations are subjecting them to a higher likelihood of developing a cancer, then those mutations may, in fact, be resulting in multiple cancers. So thyroid cancer may be one of them, but there may be other cancers that may be resulting because that same mutation is subjecting to those patients to other types of cancers as well. So yes, we have seen certain mutations that are causing more than one cancer in a given patient.
Yeah. So are the mutations that you're referring to, like we talk about the integrin receptors on the outside of the cells, and T4 can bind to those, and that can cause cellular replication? Is it mutations with the integrin receptors, or are we talking about like FOXO gene mutations and things like that?
There are multiple ones. So there are sometimes these mutations where we have our own T4, CD4 and CD8 cells that are preventing the cancer cells from growing once they are. So if there's a potent CD4 CD8 combination, and if the cancer cells are developing somewhere, if those cells find out, they kind of attack and put the end to their growth. But there are certain mutations that prevent our own cancer immunity to work effectively.
Sure. I mean, and there's things that suppress natural killer cells, or we get overwhelming of natural killer cells, and they can create a lot of issue and challenge. I've just read I've read a lot of papers in looking at this, because part of my philosophy has been that when we think about what's going on in the body, oftentimes we think about the body being broken. And I think there's an innate intelligence in the body. And it's been my argument, I guess, for a while, that especially from a hypothyroid perspective, I look at it through the lens of the cell danger response. Cells perceiving danger are going to stiffen their cell membranes, they're going to slow the metabolism, ramp up the immune inflammatory process to defend themselves. And thyroid hormone plays a big role in that downregulation of metabolism. And so it's part of my thought process. I wrote about this in my book, that maybe when we see hypothyroidism, this is actually a protective response. And maybe before we jump in there with thyroid medication, we should be asking, what the heck is going on here? Because if T4 can bind, there's abnormal cells, and T4 can bind to those integrin receptors and cause cellular replication, could there be a greater risk for people developing cancer who are put on thyroid medication? Maybe, and sometimes you have to do that because there isn't enough thyroid hormone in the system to really support the system, but maybe sometimes too early, just because somebody's symptomatic and we want to help them. And there are, I think 2019 started seeing papers coming out saying, hey, maybe hypothyroidism is a protective response. Maybe it's a protective response. And so I from my perspective as a functional medicine practitioner, I'm always trying to look at what's at the root issue. And I think we need to be very cautious when we're providing the medication. And I think my industry, the integrative and the functional space, may be a little too aggressive at times, providing thyroid medication to manipulate a lab value or manage symptomatology, versus pumping the brakes a little bit and saying, hey, maybe we got to decide what maybe is triggering this cell stress inflammatory process before we add more hormone to the system. So that
Absolutely. In fact, there's a changing practice paradigm to precisely what you just mentioned. So there was a concept that once the thyroid gland is removed, then once you treat them with the thyroid hormone, is that you want to be more aggressive. The reason being that if you increase the hormone level, then the TSH is suppressed, and that TSH is the cause for thyroid cancer to come back, stimulating it. So there used to be an approach where you on purpose wanted to make these patients slightly hyperthyroid. So not just replace the hormone, but aggressively repress so that they are a little hyperthyroid. And theory was that that may, in fact, help in reducing the number of cancer recurrences of thyroid cancer. Currently, that paradigm is shifting, and the endocrinologists are no longer as aggressive in replacing the thyroid hormone. So in a way, it's indirectly benefiting to the concept you just mentioned.
Yeah. And part of the issue too is the deiodinase enzyme, deiodinase 2, which is the primary converting enzyme of T4 to T3, as you suppress TSH and saturate with T4, that downregulates deiodinase 2. It ubiquinates it. Now, in an effort to suppress TSH, we've got more T4 in the system than maybe the cells and tissues needs. It's actually creating a hypothyroid state in many tissues. So now you've got a patient who, and especially if there's inflammatory processes going on and there's upregulation at the HP axis, now we've got maybe too much T4 impacting that, upregulating the sympathetics, downregulating the parasympathetics, and we might have a hypo type symptomatology in our patient all at the same time. And then again, if that patient has chronic immune inflammatory processes, abnormal cell development, and potentially some of that hypothyroidism was a protective response, do we potentially ramp up the immune are we on this cascade? So I think at some point, we'll start to fine tune the combination of, hey, we need this crisis care. Like we need to do this today. We also, for the patients who are willing to comply, we need to get in there and modify lifestyle habits, behaviors, so we don't have these things continuing to progress or create new cancers somewhere else in the body potentially.
Right. And the current practice paradigm shift seems to be helping in that regard, that there's not as much sense of aggressiveness required to replace the thyroid hormone.
Absolutely. So you're using this therapy. We talked a lot about thyroid from a perspective, but we can use this similar technology in other tissues. You talked about endocrine tumors, and we talked about the prostate. Not every hypothyroid patient is female. So let's talk about how you're using this treatment for these other tissues and what the positive effects are.
Yeah, so it's with regards to the proof of concept, it came from two different cancer applications. One is in the neuroendocrine space, and the other one is in the prostate cancer space. And while these treatments were being used in Europe for several decades, it was not until about only 10, 11 years ago that the trials started to take place in US. And these trials looked at treating the theranostic approach, applying it to, first it applied to neuroendocrine tumors, and there was a trial that came out called NETTER-1. And that trial, in fact, showed that these patients who were treated with this theranostic approach using lutetium-177 dotatate. So your point about radiopharmaceuticals, the radio side was lutetium-177, the pharmaceutical was dotatate, and they were targeting the metastatic neuroendocrine patients. And what it found was that compared to the control arm, the patients in the active arm lived longer, they had less progression of the disease, and overall their symptoms also improved. So that trial ultimately resulted in the approval of these treatment in 2017. And then came the approach application to prostate cancer, and that approval came in 2022. So with these two models that are so successful in showing the improvement in the outcome, we are practicing theranostics in these two cancers, but at the same time, there are numerous trials in other cancers as well. In fact, the last I checked was just 2 days ago when I gave a lecture to a European Nuclear Energy Agency group, and that agency had invited me to speak because they wanted to understand the supply chain and the demand for these treatments in the future, which is projected to be exponential. So there are multiple government agencies, both US Department of Energy, the European Nuclear Energy Agency, and South Africa and other countries that are all coming together to make sure they get ready for this new paradigm that is going to mandate the treatments in so many other cancers. So they need to be ready for these treatments. And what I was talking about at that particular setting on the venue was that not only these treatments are applied in neuroendocrine and prostate cancer in the later stage, but increasingly they're applied in the earlier stage of the disease. And as we go earlier and earlier, we are finding that the outcome benefit is even stronger when we treat early. So I think this entire field of cancer therapeutics is now going into this exponential growth of radiopharmaceutical therapy in multiple cancers.
And so the hope will be in the future, we can be more targeted, less systemic compromise,
Correct.
right? And obviously less potential side effects from getting treatment. So that would be the goal moving forward. Like, and just
Absolutely.
really hone in on just, hey, we're really only affecting kind of the local tissue right here, kind of leaving the rest of the tissues in pretty good shape to be able to recover.
Right. So this Human Genome Project, was successful about 25 or so years ago. And right at that time, there was discussion of multiple terminologies came in: precision medicine, personalized medicine. Unfortunately, it took us a couple of decades, but ultimately we are reaping the benefits of knowing what that Human Genome Project provided us the information and using the current technology. And thankfully, our radiochemists, who are a very smart group, they figure out the ways, to your point, not only continuing to approach the targeted treatment with less side effects, but they are in fact working on even refining it to a point that even stronger expression occurs at the tumor sites and even less side effects to the normal tissue. So what we call a therapeutic index keeps growing because of their continuous drive to innovate and reinvent.
Yeah. So as they innovate and learn more, they can be even more targeted to just those specific cells and have less reciprocal damage to surrounding tissues.
Yeah.
So we'll start kind of wrapping this thing up. If somebody's diagnosed thyroid cancer, prostate cancer, a neuroendocrine cancer, what are there lots of options today, or are there lots of clinics kind of doing what you're doing, or is it still kind of siloed into, there's only a few people really pulling all of this kind of more specific targeted technique together?
So there are more people involved in it because it is so powerful in the way it changes the outcome. But majority of the practice is in the major academic centers and hospital-based practices. We are innovative in the sense that we realize that this potential of administering these diagnostic and therapeutics in a theranostics form is so much more applicable in the outpatient setting, because patients in a hospital setting have to go to multiple stops, registration, triaging. We provide a very streamlined approach where they come in. They are outpatient centers that are conveniently located in where the patients are. So they have to spend less time in traveling, less time in logistics and registration, and get to the core of the treatment options where they just come in and get appropriately treated. Now, In terms of providing these, you have to be completely equipped with it because, as we mentioned, the theranostic approach goes into both diagnostic and therapy. So you need to provide the available imaging techniques, not just treatment itself. So our centers are equipped with inevitably having the scanners as well as infusion rooms that are tied together, so you can provide all comprehensive service. Regarding your question about which patients are going to benefit from this. So when they're diagnosed, unfortunately, not every patient is diagnosed at a same stage of the disease. We wish that we diagnose them at such an early stage that we can provide them the best curative options. Because of the heterogeneity of several settings, including the available imaging and therapeutic options where patients live, socioeconomic status, the insurance coverage, many times we find that patients are either diagnosed at a very late stage or diagnosed at an intermediate stage because of those limitations. When that happens, our treatments are more approachable to them, more available to them in the earlier stage, in this right away, as opposed to those patients who are diagnosed at a very early stage where they undergo surgery. In that case, we come in when the cancer comes back. So it depends on what stage of the disease they are diagnosed. That's where the theranostic approaches really become practical and applicable to them.
So let's just say somebody gets diagnosed with possible or no, they get diagnosed with thyroid cancer, potential thyroid cancer. What if it's based, you're saying based on the stage, but a lot of people get diagnosed with thyroid cancer and this is like a shock to, they don't know what to do. They don't know where to go. What's the thinking process? If it was you who got diagnosed, like what would you be thinking? You would just go to see, or should somebody be looking for a specific, a specific specialist? Is there something they're looking for? Like from your office, how do they know that they're looking for potentially for your type of care or your type of center?
Yeah, so if they are diagnosed with metastatic disease and they or recurrence, right? So there are two different settings where this could happen. One, somebody who had known thyroid cancer and was in remission, and now the thyroglobulins started to go up and there was suspicion. That's when we get these patients for scanning to find out if the cancer has come back. Once we do the scan and we confirm that cancer has come back, then we report back to the referring provider and we have a discussion. Well, look, this cancer seems to have a high degree of expression of iodine, so it is amenable for radioactive iodine treatment. Then we prepare these patients appropriately, put them on a low iodine diet, and then plan their treatment. Same way, if the patients with prostate or neuroendocrine tumors are diagnosed with extensive metastatic disease and other treatments have failed, we get a phone call or email or a referral saying that, look, we tried other options, these treatments didn't work. We think that now there is a great promise from theranostic approach. Would you mind first doing the scan, confirming that there is a target expression of these cancers, and then treating them with the appropriate treatment in the theranostic pair?
Okay. I may have misheard what you said. But for most people who are early on, let's say thyroid cancer, their thyroid glands, they may go through a traditional thyroidectomy, radioactive iodine treatment. It's usually, if it's coming back, those are the types of patients that your treatment might be the most effective on. Or if somebody has their thyroidectomy and then you might treat them, but they're typically have already had the thyroidectomy before your process becomes appropriate.
Right. So typically they may be seeing their primary care physician or an endocrinologist who then diagnoses a cancer, sends them to the surgeon, and then surgeon does the thyroidectomy, and then we get the referral from any one of these three sources. Either a primary care would send the patient back, or an endocrinologist would send the patient to us, or a surgeon would say, look, I did my part, I removed the thyroid, you now need to go and treat with the radioactive iodine.
But that person's, if they didn't come see you for Theranostics, they went to somebody else for just traditional radioactive iodine treatment, would it be different?
No, so we actually do give the radioactive iodine
No,
treatment.
that's I get that's part of the treatment. But
Correct.
I guess if I'm the listener and I'm listening to it, what's different? They may be thinking, is there something different about your process than what I would get? Why would I defer to your process, your theranostic process, versus going and getting done radioactive iodine somewhere else?
So the radioactive iodine still is not available everywhere because it requires appropriate licensing. So an
Right.
endocrinologist cannot treat with the radioactive iodine unless there are a few things required. They need to have appropriate training. They need to have authorized user status by the Nuclear Regulatory Commission, and they need to have the appropriate lab that maintains it, that's heavily regulated. So most endocrinologists are really not equipped for these treatments. Inevitably, they would send the patients to us. So whether the patients are seeking us out directly or they're seeing their endocrinologist, ultimately we are the ones who will give that radioactive iodine treatment.
Yeah, and maybe I'm not asking this appropriately, but they could go to multiple neuromedicine practices, right? Lots of options.
Nuclear
Is there,
medicine, yeah.
right? So what differentiates what your group is doing from the other neuro nuclear medicine practice? Is there something different going on in your practice than traditional neuromedicine practice, or is it pretty much all the same? It's just this is where nuclear medicine is going.
So nuclear medicine practice can be done in a hospital setting, so they may prefer to go to the hospital, or they can come to a standalone practice like ours. What we provide is a convenience factor, which is very unique in the sense that the amount of time the patients need to spend in the logistics before they see a nuclear medicine physician is considerably shortened and streamlined in a practice model like ours. Whereas if they go to other places, they have to go to multiple registration steps, multiple triaging steps before they actually get to see the nuclear medicine physician. So what we provide is the same expertise, but in a much more streamlined and convenient way. We are in a professional building where the patients park their car, they just come right up and they are ready to see us for their treatment discussions.
Yeah, I just wanted to clarify
Yeah.
to separate it, because we're talking about all this stuff and then somebody might be like, do they do something different? Really what you've done is say, we're going to take it out of this kind of complex, hit all the different spots maybe in a hospital setting that you have to do. And we're going to make it a one-stop shop where you can come in here. We can do it from start to finish. You don't have to go to multiple different offices. You don't have to see multiple different clinicians. We can do it all right in one space. The imaging, the treatment, and everything can be done in one space, just to make the whole process more convenient for the individual, right?
Right. I would put it in 2 words: concierge medicine, literally, because that just provides all the streamlined, personalized approach with very minimal loss of their personal time and inconvenience that we remove from their experience.
Sure. So we'll finish up with this. Where do you see nuclear medicine, and especially in regards to thyroid care, where do you see it going in the next 5 to 10 years? I was going to say 10 to 20 years, but everything moves much faster today with technology. So where do you see it headed in the next 5 to 10 years?
So there are a few things, there are, for example, more sophisticated imaging techniques that are really helping. So, as I mentioned, our therapies are so tied into our diagnostic, which is why we call it Theranostics. So the imaging equipment is getting very sophisticated. So it allows us to pick up more extensive disease, picking up every site that matters for the treatment in a more effective way. There are also other approaches. For example, not all iodine are the same. So we talked about radioactive iodine of I-131, I-123. There's another one which is called I-124. And that molecule is extremely promising. And I would hope that over the next 5 to 10 years, that molecule catches on into clinical practice, because that uses a PET scan, and that iodine 124 using the PET scan can be extremely valuable in our clinical practice in the future. Because if we were to plan out our treatment, exactly how much treatment is needed, we need to do a very sophisticated calculation up front before we treat. And I-124 PET is very, very effective in giving us the exact idea of what type of treatment is needed. Because ultimately, I know in medicine, we don't talk too much about cure in a cancer, but I think we need to talk about that. And if the patient is just given a few years of extension of life, it's very different than giving them the best chance of cure. And that's where tying into these diagnostic and therapeutics are going to be very critical. And then, as I mentioned, the other part is having more and more sophisticated measures to redifferentiate those cancer cells of thyroid that are dedifferentiated, because then we are preparing them for the appropriate target using the I-123, I-120, I-131 treatment, because if they don't have the expression of iodine, we can't treat with I-131. So
Right.
those techniques are also getting more and more refined.
How about with the advances in AI technology? How do you see that potentially changing nuclear medicine and what you're doing?
Actually, it's already happening. In fact, one of my monitors on the side is blank right now for right reason, because I want to have the protected health information covered. But just last week, we had a patient in whom we used the AI algorithm to appropriately calculate the dose that we wanted to give in a thyroid cancer patient. And the idea there was that this patient was just initially diagnosed, but had extensive disease over the body. So we know that when you treat the thyroid cancer, or for that matter, prostate or any neuroendocrine or other cancers, your best chance of cure is your first encounter. And in that case, we wanted to make sure that we give the highest possible dose, but we didn't want to go so high that the normal tissues start to get the side effects of that. So all of that calculation required upfront imaging and very sophisticated calculation. We use the AI algorithm to do that calculation in our practice. So in many ways, our field is very ripe for using the AI because we are quantitative. And whenever there's a quantitative benefit, AI is very naturally suited to take full advantage of that.
Absolutely. Yeah, it's crazy where we've come in such a short period of time with the AI technology. It's going to be amazing in the next, I'm sure, 5-10 years.
Yeah.
We'll be shocked. We'll be thinking about what we do today and be like, man, that was like the Stone Age, kind of like cell phones. And when now we had the cell phone, back in the day, we had a pager. Anyway, I appreciate you coming on the podcast. I think it was very informative. If people want to learn more about your company, where can they go?
So they can go to unithera.com, which is our website, unithera.com. And we have multiple centers that are opening up all over the country, and they are all managed in a very sophisticated way so that the practice and the standard of care that patients receive are exactly the same, whether they go to one part of the country or the other. They are all meeting that benchmark that we have set forth for our practice of Theranostics.
Perfect. Well, I appreciate you coming on, and I'm sure we may have a conversation maybe sometime in the future if new technology occurs. All right.
Thank you, Dr. Balcavage. I really appreciate the invitation, and it was wonderful speaking with you.